today's class will be on the tetanus. And if time permits, I would like to talk on cholera and bacillary dysentery at the end of the tetanus. Each may last for about 10 to 15 minutes. Now we'll move on to the tetanus. It's a neurological disorder caused by a neurotoxin. There were the two neurotoxins caused by Clostridium tetani. One is tetanospasmin and the second one is tetanolysin. And tetanospasmin is almost 98% neurotoxic. So this is there will be the increased muscle tone and the spasms. So you will see, identify any tetanus patient, he will have a lot of the spasms and the increased tone. As I told you, this is a powerful protein toxin, tetanospasmin. It occurs in the several clinical forms. There are really the 4 forms are there. Fourth one is not here. One is the generalized tetanus, localized tetanus, neonatal tetanus, and cephalic tetanus. Cephalic tetanus is nothing but first it started as a localized tetanus in that particular area, and then later it may convert into the cephalic presentation of neurological origin. So this tetani, Clostridium tetani, is an anaerobic organism, a motile, a gram-positive. It forms an oval, colorless and terminal spore resembling a tennis racket or a drumstick. It is found worldwide, mostly in the soils. So when a fellow happens to get injured with the wounds, with abrasions, with abscesses, formations, etc., it will enter into the body. And the earlier days, it was most of the tetanus were seen in the age group of 0 to 5 years because of the umbilical cord stumping in an septic maneuvers. Sometimes it may be in the inanimate environment and the animal feces and the human feces, but mostly 98% is it in the soil form. The spores survive for years in some environments, and they are resistant to various disinfectants and the boiling for the 20 minutes. Vegetative cells, they are easily inactivated, susceptible to the several antibiotics. That is the reason we use the metronidazole and the penicillin in the management of the tetanus along with your immunoglobulins. So to attack these vegetative cells. This tetanospasmin, a neurotoxin, is formed in the vegetative cells under the plasmid control, a single polypeptide chain. It is having the 2 chains, heavy chain and the light chain. Heavy chain mediates the binding to the nerve cell receptors and entry into these cells. And the light chain acts to block the neurotransmitter release. So your GABAergic pathways, presynaptic pathways, that will be blocked, and there will be more and more catecholamine release, and there will be the tachycardia, tachypnea, hypersweating, spasms, so etc. So finally the person goes into respiratory failure. So the most common cause of the death in tetanus is the respiratory failure. So endotracheal intubation and tracheostomy, so these are very much needed in most of the cases of the tetanus. Otherwise these people are going to die. But nowadays with the good availability of these high-tech facilities, almost the mortality has come down from 100% to maybe 30 to 40% right now. So the amino acid structures of the 2 most powerful toxins known, the botulism toxin and the tetanus toxins, are partially homologous. So it's a common toxin. Very close to this tetanus toxin is the botulism toxin, which is again a very dangerous toxin. So it occurs sporadically, always affects the non-immunized persons, those people who are not immunized. So that is the reason now the immunization, even in the children also, at the 2 months, 4 months, 6 months, and then the 16 months. So they will take the 4 shots of this tetanus along with the diphtheria. And then at the age of 5th year, they will take 1 booster dose. And again at the age of 12 years or 13 years, they take another booster dose. And later in the adult's life, once in 10 years, one has to take the booster dose of this tetanus to avoid tetanus presentation. So it always in non-immunized persons. I think nowadays the most of the 90% of the population are immunized. Or partially immunized populations are very high because of, as I told you, booster doses, as long as they are the pediatric age group or in the neonates or the children, they take the vaccination very clearly. But once they reach the 12 years, 13 years, they are supposed to take another booster dose of the tetanus, which may be missed in most of the people. And then in the adults, once in 10 years, they have to take these booster doses, that also going to be missed. So most of the people comes under partially immunized persons, or fully immunized individuals who fail to maintain the adequate immunity with the booster doses of the vaccine for some reasons. It is entirely a preventable disease, 100% a preventable disease, provided if they take the immunization as I told you. So common in areas where the soil is cultivated, the rural areas, warm climates, during the summer months, and among the males. So this is a very common in these population. In countries without a comprehensive immunization program, tetanus occurs even in the neonates and the young children, especially in the African countries and in the rural India. So home deliveries, clumping. So these are very common areas of causing the tetanus. Nations with the successful immunization programs, neonatal tetanus is almost rare. Affects other age groups and groups inadequately covered by the immunization. The risk is highest among the elderly individuals. For tetanus and the severe illness, only 27% of the persons aged 70 or older, as opposed to 88% of the 6 to 11-year-old have the protective antibody levels. So if you see the protective antibody levels, they will be very high in the younger individuals when compared to the elderly individuals. So the elderly individuals are more prone to the tetanus because of these low levels of the antibodies. So age and the disease, more than the 60 years, 35% of the cases, 20 to 59 years, it is about 60%, under 25%. Most cases of the tetanus follow an acute injury, such as the wound or laceration or abrasion. It is acquired indoors and outdoor activities during the farming and the gardening. The injury may be the major or trivial, so that the medical attention is not sought. But some instances, no injury can be identified to the patient, but still because of some abrasions, so these spores or this tetanus or Clostridium tetani may enter into the body, and then they reach the axons and then cause the more and more neurotoxins. The disease may complicate the chronic conditions such as the skin ulcers, abscesses, and gangrene. These are very common in our diabetic individuals or CKD individuals or people with HIV positivity. So those people are more prone to these conditions. It is also associated with the burns, frostbite, middle ear infections, or CSOM, post-surgery, abortions, childbirth, drug abuse, especially heroin. In some patients, no portal of entry for the organism can be identified. So if you go to the pathogenesis, contamination of the wounds with the spores of the Clostridium tetani is probably the frequent. Germination and the toxin production take place only in the wounds with low oxidation reduction potential, such as those with the devitalized tissue, foreign bodies, and active infection. Clostridium tetani does not itself evoke the inflammation, but portal of entry retains a benign appearance unless the infection with other organisms is present. So mostly it requires another organisms like your Staph aureus, etc. to enter into the body. The toxin released in the wound, so there is the localized tetanus, that binds to the peripheral motor neuron terminals, that enters the axon and is transported to the nerve cell body in the brainstem and spinal cord by retrograde intraneuronal transport. The toxin then migrates across the synapse to presynaptic terminals, where it blocks the release of the inhibitory neurotransmitters like glycine and GABA. So that is how the toxin, which enters at the area of your wound or the abrasion, goes to the central nervous system, and finally it attacks the glycine and the GABAs. The toxin also acts principally on the spinal cord, altering the normal contraction of the reflexor. That is how the people will have the spasms, bow necks, and then the movement of the thorax, movement of the abdomen, etc. So there will be the hyperextension of the neck, jaw, neck. By suppressing the inhibition regularly mediated by the intranuclear intranasal neurons, as a result of this suppression, for example, contraction of the biceps is accompanied with the contraction of the antagonist muscle like the triceps, producing the spasm. So both the agonist and the antagonist muscles will go into the spasms. So here it is a synapse. See, if you concentrate here, there is the presynaptic inhibitory neuron, the main site of the tetanus toxoid action. So there on the left side. So finally it diffused into the extracellular space and entire axon, the toxin will be there, and there will be the retrograde intraaxonal transport to all the skeletal muscles. From there the retrograde intraaxonal transport, and finally the muscle fiber will be involved, and then there will be some spasms and the tics. So the loss of the inhibition may also affect the preganglionic sympathetic neurons in the lateral gray matter of the spinal cord. So not only your brainstem in the axons, here the spinal cord also very much involved in the tetanus. It produces the sympathetic hyperactivity and high circulating catecholamine levels. So there will be the tachyarrhythmias also. So that is the reason in a tetanus we use the bismolol. So that is a beta blocker to reduce the tachycardia. And there will be the autonomic dysfunction also very common in the tetanus individuals, autonomic disturbances. So this neurotoxin by name tetanospasmin, like your botulinum toxin, block the neurotransmitter release at the neuromuscular junction and produce the weakness or the paralysis. Recovery requires spouting of the new nerve terminals. In the local tetanus, only the nerves supplying the affected muscles are involved. Here the recovery is good in the local tetanus. Mostly the 98% of these people, they survive unless they go into the cephalic form. Generalized tetanus occurs when the toxin released in the wound enters the lymphatics and the bloodstream and spread widely to the distant nerve terminals very fast. Maybe here the incubation period may be 1 week to 2 months. The blood-brain barrier blocks directly entry into the central nervous system. Short nerves are affected before the long nerves. This fact explains the sequential involvement of the nerves of the head, trunk and extremities in the generalized tetanus. So most of the tetanus, the first appears in the neck, in the face, and then only in the limbs. So because of the short nerves. Clinical manifestations, as I told you, there's the 4 forms of the tetanus: generalized, neonatal, local, and cephalic. 80 to 85% is the generalized tetanus. That is very common. It is the most common form. It is characterized by the increased muscle tone and the generalized spasms. The time of the onset of the injury is the 7 days. 15% of the cases occur within the 3 days and 10% after the 14 days. Patient first notices the increased tone in the masseter muscles, that is the lockjaw, also called as the trismus. Then there will be the dysphagia and stiffness or the pain in the neck, shoulder and the back muscles. And subsequent involvement of the other muscles produce the rigid abdomen and stiff proximal limb muscles. Hands and the feet are relatively spared here. So first mostly the face, neck, and then the trunk and the abdomen, and usually the hands and the feet are mostly not involved here. There will be the sustained contraction of the facial muscles, result in a grimace or the sneer. The word given to that posture is the risus sardonicus. Back muscles produce an arched back, that is opisthotonus. So opisthotonus and the risus sardonicus, these two are very common in our tetanus population. So in the extensive generalized tetanus, so it is almost like a spotter to diagnose it as a tetanus because of this lockjaw, trismus, and then the facial muscles results in the grimace, that is the risus sardonicus, and then the arched back, that is the opisthotonus. So you don't require any investigation to diagnose the tetanus here. So high index of suspicion must be there to diagnose the tetanus, and these two will definitely clinch the diagnosis of the tetanus clinically. It's mostly a clinical diagnosis, tetanus. Some patients develop the proximal, violent, painful, generalized muscle spasms, may cause cyanosis and then threaten the ventilation also. Once it involves the chest muscles, so definitely there will be the respiratory failure, and so they need a mechanical ventilation. So endotracheal intubation, etc. So there is a very much needed, and tracheostomy, so to avoid the death. Spasms occur repetitively and may be spontaneous, provoked by even the slightest stimulation. So they want the dark area. So that is the reason most of the tetanus individuals know. So we keep it in the dark area. A constant threat during the generalized spasm is reduced ventilation, apnea, laryngospasm, lot of the secretions, and there will be the aspiration, pneumonias, etc. So the tracheostomy and intubation is very much needed in this population. Severity of the illness, mild, moderate, and the severe. Mild muscle rigidity and the few are the no spasms. very few people, lucky population. Here the prognosis is 100% good, whereas the moderate and the severe, so definitely these people are very troublesome people. So with the trismus, with the dysphagia, with rigidity, with the spasms and explosive paroxysms, so they need very high care of the intensive management and with a mortality rate of about 30 to 40%. Patient may be febrile. Here the fever is very rare in tetanus, but may have no fever most of the times. Mentation unimpaired. Deep tendon reflex may be increased, and dysphagia bilious, they prevent the oral feeding, and if the otherwise they will go into the aspiration pneumonias. As I told you, autonomic dysfunction is very common in tetanus individuals. So it complicates severe cases. So once the patient is having the autonomic dysfunction, it is a very severe tetanus with a labile or sustained hypertension. So the blood pressure will fluctuate very high. There will be the tachycardia, the heart rate will be about 160, 180, 200. These arrhythmias, there will be the tachyarrhythmias, hyperreflexia, profuse sweating, peripheral vasoconstriction, and increased plasma and urinary catecholamine levels. So these are all the features of the autonomic dysfunction. There will be the bradycardia, and the hypotension may also be documented in some cases. Sudden cardiac arrest is very common here. And other complications like, as I told you, aspiration pneumonia, fractures because of these spasms and the contractures, muscle ruptures, DVT, pulmonary emboli, decubitus ulcers, rhabdomyolysis are the common complications we often notice in tetanus if they live for a longer period. Otherwise, you don't see the pulmonary emboli, deep vein thrombophlebitis, decubitus ulcers, rhabdomyolysis. With respiratory failure, most of the people they die. Neonatal tetanus usually occurs as a generalized form and is usually fatal if left untreated. So that is the reason mortality of the neonatal tetanus is very high. In children born to inadequately immunized mothers, that is the reason nowadays all the pregnant mothers should be given a tetanus injection. So between 27 to 35 weeks of the gestation, without the prior history of immunization history. So whether they immunized or non-immunized, so every pregnant woman has to take one TT between 27 to 35 weeks of the gestation. So in children born to inadequately immunized mothers, so definitely they are prone for neonatal tetanus. Unsterile treatment of the umbilical cord stump. So in the rural India, now you go back to 50 years ago or 100 years ago, so most of the people, they applied a lot of things on the umbilical stump, cord stump. So that was the reason for the neonatal tetanus at those times. So even tetanus is very common nowadays in Africa because of these measures. Its onset generally comes during the first 2 weeks of the life. Poor feeding, rigidity, and spasms are the typical features of the neonatal tetanus. So the neonate, poor feeding, rigidity, and the spasms in the neonate. So you have to suspect the neonatal tetanus because of this unsterile treatment of the umbilical cord stump. Local tetanus are restricted to the muscles near the wound. They are uncommon. Stiffness of the involved muscles is the initial symptom, occurring days or several weeks after the injury. The stiffness and the spasms may persist for weeks in the local area and then gradually abate or trismus, and generalized tetanus may develop in a few days. Self-limited tetanus probably occurs only in the persons with some degree of immunity, in persons whose wounds contain the few organisms, and prognosis is excellent in the local tetanus, but there are very few in cases local tetanus. Most of the cases are the generalized. Most common form is the generalized tetanus, where 80 to 85%. Cephalic tetanus, a rare form of the local tetanus, follows the head injury or the ear infection. Trismus and the dysfunction of one or more cranial nerves, often the seventh nerve. Incubation period is a few days, and the mortality is also very high because of the cephalic presentation. See the picture here. See, this is the opisthotonus. So the bow body, hyperextension of the neck and the trunk muscles, and then lower limbs, etc. A typical picture, almost like a spotter to diagnose the generalized tetanus. See here the cephalic tetanus. So the first picture represents with the bilateral seventh nerve palsy, lower motor. In the second one, a partial recovery, and finally total recovery. See, this is the neonatal tetanus, the spasms, stiffness. Okay, very unfortunate. So these people are going to die with the neonatal tetanus. So diagnosis mostly the clinical, based entirely on the clinical findings. Unlikely if the reliable history indicates the completion of the primary vaccination series and the receipt of the appropriate booster dosages. Wounds should be cultured in the suspected cases. Clostridium tetani can be isolated from the wounds of the patient without the tetanus. In the same way, frequently cannot be recovered from the wounds of those with the tetanus also. The leukocyte count may be elevated. CSF examination is normal because to rule out your meningoencephalitis. So common DD for the tetanus is the meningoencephalitis, where that will be abnormal in the CSF fluid, whereas the tetanus, the CSF is the normal. Electromyograms may show the continuous discharge of the motor units and shortening or the absence of the silent interval normally seen after an action potential. So EMCs. Muscle enzyme levels may be raised for a CPK NAC. Serum antitoxin levels more than 0.01 units per ml are considered protective and make the tetanus unlikely. Although cases developing that despite the protective antitoxin levels have been reported, but no one gets these antitoxin levels. So DD, very common DD here in our areas is the meningoencephalitis and then the hypocalcemia. Hypocalcemic tetany is also present like this. Strychnine poisoning. Dystonic drug reactions, especially our metoclopramide, phenothiazines. So the drug hypocalcemias, strychnine poisonings, and meningoencephalitis. These are the common differential diagnoses for your generalized tetanus. Confused tetanus include the meningoencephalitis or meningitis, rabies, acute intra-abdominal process because of the rigid abdomen, markedly increased tone in the central muscles, face, neck, chest, back, and abdomen, with generalized spasms, relative sparing of the hands and the feet, so strongly suggests the tetanus. So these are the very important points because the tetanus diagnosis is mostly a clinical diagnosis only. So what about the treatment aspects? So we give the IV tetanus antitoxin, so to neutralize whatever the toxin is there, and also to arrest the already formed toxins action. Injection penicillin, as I told you now, to kill the vegetative forms, we can use the penicillin and the metronidazole. Debridement and cleaning of the wound to prevent the further production of the toxin there at the localized wounds. Patient to be managed in the quiet room. IV diazepam to reduce the spasms, sometimes magnesium to reduce the spasms. And proper nutrition and hydration is very, very important. And maintenance of the airway is very important because the respiratory failure is the most common cause of death here. So endotracheal intubation and early tracheostomy. So these are the lines of management. So tetanus antitoxins, some antibiotics like penicillin and metronidazole, and the debridement and the cleaning, quiet room, diazepam or the magnesium sulfate to reduce the spasms, good nutrition, hydration, and then the airway maintenance. They should be admitted in the quiet room in an intensive care unit where the observation and cardiopulmonary monitoring can be maintained. Protection of the airway is vital. Wound should be explored, carefully cleansed, and thoroughly debrided. Don't suture it. So don't suture the wounds of the in a tetanus patient. So they should be opened, they should be explored. Antibiotics, we use both the penicillin and the metronidazole. So metronidazole, 500 milligrams every 6 hourly or 1 gram every 12 hourly. Usually we give 500 milligrams TID. Penicillin G, your benzyl penicillin, 10 to 12 million units. Intravenously, maybe 6 hourly for about 7 to 10 days. Survival rate higher than that obtained with the penicillin in one non-randomized trial, and the absence of the GABA antagonistic activity seen with the penicillin. Clindamycin, erythromycin, those people who are sensitive to the allergic to the penicillins. The antitoxin is most important, given to neutralize the circulating toxin and unbound the toxin in the wound. Antitoxin effectively lowers the mortality. Toxin already bound to the neural tissue is unaffected. So antitoxins one should use. So here it is human tetanus immunoglobulin. It is a preparation of the choice and should be given promptly. The dose is about 3000 to 6000 units. You can remember as the 5000 units intramuscularly. And some of these dose has to be given at the localized wound area also. So usually in the divided dosages. Pooled intravenous immunoglobulins may be an alternative to the TIG, that is tetanus immunoglobulins. But the specific antitoxin concentration in this formulation is not standardized. Best to administer the antitoxin before manipulating the wound. Value of injecting a dose proximal to the wound or infiltrating the wound is unclear, but still we give the some of these antitoxin injections at the localized area of the wounds. Additional doses are unnecessary. Half-life of the antitoxin is very, very long. The antibody does not penetrate the blood-brain barrier. So intrathecal administration considered experimental. We don't give it as intrathecal administration. Equine tetanus antitoxin, cheaper than the human antitoxin. Half-life is very short. Commonly instils the hypersensitivity and the serum sickness. Muscle spasms, they're painful and can threaten the ventilation by causing the laryngospasms or sustained contraction of the ventilatory muscles. So many agents alone or in combination have been used, especially with diazepam and magnesium. Abolish the spasmodic activity without causing oversedation and hyperventilation. Here the diazepam, a benzodiazepine and a GABA agonist is in wide use. Larger dosages more than the 250 milligrams per day may be required. And other options, lorazepam, midazolam. Lorazepam is a longer duration of action, whereas midazolam is a shorter half-life. Second line drugs, barbiturates and the chlorpromazine. Spasms and response to the medications are the spasms that threaten the ventilations. Immediately therapeutic paralysis with a non-depolarizing neuromuscular blocking is and mechanical ventilations. Here we need the intensivist help, especially the anesthetist help. Alternative agents include the propofol, which is expensive, and the datrolene and the baclofen. So baclofen we often use in the GERDs also, are being investigated in the hope of shortening the period of the therapeutic paralysis. So respiratory care, tracheostomy and intubation with or without the mechanical ventilation, oversedation, laryngospasm, the avoidance of the aspiration. So these are very, very important. So with the trismus and disordered swallowing at the dysphagia, the need for this procedure should be anticipated and undertaken electively and early. That is very, very important. So anticipation and early ventilation and early tracheostomy is very important. So don't wait till the respiratory failure occurs. Before that, you have to do it. And autonomic dysfunction. So the optimal therapy for the sympathetic overactivity has not been defined. Agents that have been considered include here labetalol or esmolol. So both the labetalol is both alpha and beta. Now it's the drug of choice in pregnancy hypertension. So earlier you used methyl dopa. Now the labetalol is the drug of choice in pregnancy hypertension. So it's both alpha and beta blocker. That is recommended by some experts, but that report has not has caused a sudden death. Esmolol, a continuous infusion. It's a beta blocker available in the parenteral form. Clonidine, a central acting antiadrenergic drug, and morphine sulfate. Parenteral magnesium sulfate, so to reduce the spasms, etc. Continuous spinal epidural anesthesia have been used, but may be more difficult to administer on the monitor. Hypotension or bradycardia, they require volume expansions with your regulated, etc. or albumins, vasopressors, chronotropic agents, and pacemaker insertions. Vaccines, big thanks to the vaccine because it's almost protective, 100% protective. Patients recovering from the tetanus should be actively immunized. Immunity is not induced by the small amount of the toxin that produces the disease. So whatever the toxin is there, it will not produce the antibodies there. We have to give the vaccine. Hydration, meeting the patient's increased nutritional requirements by enteral and the parenteral means. Physiotherapy to prevent the contractures, to avoid the muscle rupture. Administration of the heparin and other anticoagulants to prevent the pulmonary embolia and DVT. Bowel, bladder and renal functions must be monitored. Gastrointestinal bleed and decubitus ulcers must be prevented. And intercurrent infection should be treated with the proper antibiotic coverage. So to prevent active immunization, 3 dosages. First and second dose are given 4 to 8 weeks apart. Third dose is given 6 to 12 months after the second dose. A booster dose is required every 10 years. Combined tetanus and diphtheria toxoid absorbed rather than the single antigen tetanus toxoid is preferred for persons more than the 7 years of the age. Wound management. So the proper wound management requires consideration of the need for passive immunization with TIG, active immunization with a vaccine. For clean minor wounds, active immunization with the TD is administered to the persons who have known tetanus, unknown tetanus immunization histories, have received fewer than the 3 doses of the absorbed tetanus toxoid, 3 or more doses of the absorbed vaccine. See, we often forget all these figures, but one thing is very clear: wound cleaning is very important, tetanus immunoglobulin is important, and active immunization, the 3 doses are important, and booster dose once in 10 years is very much needed. So vaccine should be given to those who have received 3 or more doses of absorbed tetanus toxoid if more than 5 years have elapsed since the last dose. Passive immunization with tetanus immunoglobulin is not recommended for clean minor wounds, but is given for all other wounds if the patient's vaccination history indicates unknown or partial immunization. Most of our people know, so definitely they need it because of these 2 reasons: because the vaccination history is unknown or only partial immunization. So the dose of the TIG for passive immunization for persons with wounds of average severity is 250 units intramuscularly. Vaccine and the tetanus antitoxin should be administered at separate sites in the separate injection syringes. Neonatal tetanus prevention, the maternal vaccination during pregnancy, efforts to increase the hospital births, provision of training for the non-medical birth attendants. Prognosis, application of the methods to monitor and support the oxygenation has markedly improved the prognosis in the tetanus. So big thanks to our ventilation therapies. Mortality rate as low as 10% have been reported from the units to handling such cases. So now even not 30-40%, even less, reduce it to 10%. When is an undergraduate, almost 90 to 100% tetanus mortality. So outcome is still poor in neonates, in elderly, short incubation period, short period from onset of symptoms to the first spasm, that is the period of the onset. Outcome is also related to the extent of the prior vaccination. So these are the very important poor outcome people. So neonates, elderly, short incubation period, and the period of the onset of the spasms. The course of the tetanus extends over 4 to 6 weeks. May require ventilator support for 3 weeks during this period. Some people they require even the 3 months or 6 months also. Increased tone and the minor spasms can last for the months, but recovery is usually complete. So I have to wait for the recovery. So very long duration of ventilator support is needed for these tetanus patients. So thank you very much for your patience here.